So hello everyone. Today we've got a special interview with a special guest we've got today, Dr. Jain. He is a pediatric consultant with special interest in pediatric cardiology. So he is at the front line of breaking bad news. He's at the front line of talking serious with patient about serious condition. Welcome to the show.
Thank you. Thanks for inviting me, and thanks for this interview.
Thank you. Thanks for coming to talk to us today. So let me tell you, if I took you back to your journey when you became a consultant and came to the UK, if you could tell us about your experience, how did you start your journey, and how did you end up coming to become specialized in pediatric cardiology?
Oh, very good question. Everyone does have a journey, and everyone is proud of their journey when they come this far. And I think it's not very different from with me either. Not as a consultant. I didn't come here as a consultant. I came here. I did my full qualification from India. I did my post graduation, my specialization. And when I came over here, I started as a junior doctor. They are called as resident doctor these days. And I went through all the stages of training in different hospitals, rotated all throughout the places, and eventually I became a consultant. So when you come from overseas, you don't know the system very well
Okay.
of this country, the way training posts work, non-training posts are there, and then you apply in different places because you are desperate to get into the system somehow. You don't have an idea of which job is the best job or which job is the right job for your career trajectory and which is not. So you choose some jobs and eventually you move forward. So it does slow down your pace in the beginning. I would say it's just a matter of luck as well. If you're lucky, you get the right jobs. And same thing did happen with me. I was all around in the country. Uh,
So you worked in different
Scotland, north of England, south of England, London, everywhere. And then eventually I settled down in Oxford when I got my rotation.
Amazing.
Um, and by the time I got my rotation, I was already through the system that much, and I was feeling some signs of exhaustion, tiredness, and I was asked a question in the interview that if you are given not the full rotation but fixed term contract, would you accept it or not?
Mm-hmm.
And I said, thank you very much. If you have rotation for me, I will go for that, but I will not accept fixed term.
Okay.
S- uh, uh, Probably they did like my straightforward approach that time, and I did get the rotation.
Excellent.
Uh, and
Which tell everyone, you did it, and tell everyone here that you should be clear on what's his objectives, what you want to achieve, and how to do it as well, because accepting what people offer you sometimes, if you go to an interview, may not be the best option for you. So you need to be clear about what you're expecting from the job you're applying for, and be confident about your qualification and get what you're worth.
when you start your career in the UK, you may have some clarity of your goals. Uh, of course, they do keep on changing as you see the system more closely, and then you start to like certain things and you don't like certain things. Uh, and you don't feel empowered enough in the beginning to say no to certain things, so you try to take whatever comes your way, but as you evolve into the system, you become more mature. uh, it is very important to keep the clarity of your pathway. What do you want to do? Long term settlement in this country, whether you are going back to your country and you want to extract the best out of the training and post what you want to do. And then in certain stages, if you have courage to say no to the wrong post or wrong jobs, it will probably serve you better in long run.
So when you say if you have courage, do you mean that some people should accept stuff that doesn't suit them in certain circumstances, or what's your approach on this?
Everyone has got their own uh, circumstances. A few people, they are really desperate to get a job so that they can get rooted into the country, and then they don't have very many choices whether they want to say yes or no to the job. So in that circumstances, they can say yes, even if they don't like the job very much. And once they are settled, and that's why I just use the word courage. So you gather your courage with your circumstances.
Sure.
Maybe you may have a strong personality that you are courageous all throughout.
And this is what we're trying to educate doctors to develop their muscle in saying no when it doesn't suit them. Although I agree with you completely that some doctors will be in a desperate situation and they may accept it. But even if they did at that time, it shouldn't be your approach all your life. You should be able to accept it sometimes if it's not suitable for you. Maybe work for a short period until you understand the system and see how things goes, and then move on to other job. But don't make it your habit to keep saying yes or accepting substandard offers.
That's what I wanted to say as well. And one more thing I will add on to that. Suppose if you end up accepting a job which you don't like, you still will have some opportunities of growth and acquiring new skill which are translatable to your new job, and then probably you will appear like a stronger candidate. So if you accept a job which you don't like, I'm not saying that don't give your 100% to that job. Do that job honestly, came out of that job shining, so that you have a better chances, you get very good references when you go move on to your next job.
Actually, I think this is a very valuable advice. Yeah. Even if you accepted the job, which you don't think is the best one for yourself, make sure you give it 101% to impress and make sure that you get a good reference so you can move to a better job in your career.
I will add on one thing to this theme. When I was going through my pediatric rotation and I wanted to do pediatric cardiology uh, as my special interest, I was told by my supervisor that I can't do pediatric cardiology. And it was very disheartening for me. I was told that there are so many other people who are lined up to do pediatric cardiology. Uh, what I did, I thought about it, and uh, I looked back at my journey, and I achieved few things in my life, and I did not achieve other things in my life, but I did achieve them eventually later on, maybe at a slower pace. So now, what I did, I went back to my supervisor and training program director again, and I just said, I just shared my thought processes with them. I said, thank you very much for giving me feedback. Uh, I like your honesty. I like your clarity. And you said that I can't do cardiology. I would have preferred you saying that I can't do cardiology in this rotation. And when I look back at my journey, I have done whatever I wanted to do. So I think I will do cardiology. May not be in this rotation, but I have plan B. But on the other hand, when I look back again in this rotation, I have done some less favorable jobs as well to support the training program, to support the rotation, to support the department. So I have paid my dues. And then when you think about allocating cardiology jobs to other people, I think I do have some parity, some seniority over them, and I should be treated fairly. So, but it's entirely up to you whether you want to give it to me here or not. But I just want to tell you that I will do cardiology. And my this statement had some impact on them, and actually I was given cardiology. I was given cardiology even after finishing my rotation into my grace period as well. Grace period is the period when you finish your training and you're waiting for a consultant job. uh, Generally you are put in a district general hospital just to fill the rota gap so that you don't stay unemployed. But even during that grace period, I was given cardiology, which was almost never heard of.
Amazing, amazing. Which again tells you the power of negotiation, the power of getting a message across in the right way so that it sits in the right forum to the right people in the right emotion, because you brought your emotion out, you said your intention clearly, and this, as I said, resonated well with them, and they gave you the job. So when they say to you, you are not fit to have this job, don't give up. This is the message here, right? This is a
Yes,
good message.
yes.
Don't give up, just believe in yourself and do the right stuff, but try to convincing them, work on yourself, make sure that you are prepared for the job that you're applying for, to enable them to see you as the person who is fit, who is determined, who's not being pushed away by just one single word.
Completely agree.
Yeah. Yeah. No, thank you. That's very helpful. Thanks for sharing this. It was very insightful. Thank you. I wanted to ask you now, how would you compare your clinical practice when you first arrived to the NHS system to what you're doing right now?
It's a very good question again. I would start it in a way like when I first arrived in NHS, I was from a different background, different cultural background, different medical background. Although we all do the same medical study, it's kind of a hardware, yeah. And then when you go to a different country, it's kind of a new software written on your hardware, and you adapt yourself to the practices of
It's a very good way of saying it. Yeah. Okay.
practices of that country. And then when you see your senior colleague, your contemporaries doing the job in that country, and then you see that the way they practice medicine is very different, and it can be intimidating for you in the beginning, and then eventually over the period of time you evolve. So I want to say, don't be scared of differences in the way you are thinking and the way you are seeing, the way you are doing clinical practice. Your knowledge is robust, you have reached to this point, you have passed your exams, PLAB, you are accepted, registered by General Medical Council, so you have got all the basic abilities. And now how do you translate into practice? It will keep on changing over the period of time. uh, uh, it may not be a very refined way of doing things right in the beginning, but you are in NHS training system, you are almost handheld through your processes in the beginning, and you are made a safe and competent doctor. Of course, you will bring your personality into it, and then you will evolve or develop your own clinical style eventually. So uh, my clinical knowledge definitely has increased since I started my career. My refinement of skills has definitely increased since I started in NHS as a junior doctor, and uh, I have acquired quite a few new skills as well. Uh, in last 21 years, I would say. Uh, Yes, so modern technologies, new technologies, AI integration, better communication, learning more skills, gaining more clinical knowledge, doing more courses. So eventually you evolve into a better person and a better clinician.
So what you're saying here is, for you to evolve from where you were when you first arrived, is integration to the system first, doing more courses, attending, be aware of what's happening around you, not just focused on the clinical practice you're doing, and not only keeping your clinical skill up to date, also your communication skills as well as the IT skills, and now AI.
Absolutely. So that's a very nice sum up of all the things. Doing clinical work like a clinical technician is not to be aimed for. You might do clinical work very well in very few years, but to evolve as a very good clinician over the period of time with an overall personality, which includes your communication, which is with patient communication, your colleague communication, multidisciplinary communication, it does take time, it does improve, and you have to do courses and you have to just upskill yourself as time passes.
Thank you for sharing the your experience with how to integrate and develop in the NHS. But what I want to really understand from you, because I've never done pediatric or pediatric cardiology and facing the patient with this sort of communication, it's a very critical finding you're communicating to patients and family, of course. How did you find the right way, the right pitch to communicate these serious findings, which could be complex and not understood by, you know, most people? How did you find the way to communicate this critical finding in a clear way?
Right. It's a very important question, and at the same time, it's a very difficult question to answer as well, because this is kind of a very regular occurrence in pediatrics when we see small babies and lots of emotions are involved for parents, and sometimes you are breaking the bad news regarding life limiting illness, or you are communicating them the life changing condition. And it's very important to understand the sensitivity of the situation, understanding of parents, how do they understand, what is their emotional status at that stage, because sometimes you need to communicate with them several times, because sometimes what happens, you speak one line, they switch off, no matter you keep on talking for half an hour, they
They won't
won't
understand.
they won't take it in. So you need to just keep on asking them again, what is their understanding so far, how much have they grasped, rather than giving a monologue, just emptying yourself on them. So keeping the right tone, right pitch, don't take the hope away. So I will tell you how do I do it. I start with a very open statement that what is your understanding about your child's illness so far,
Okay.
so that I don't repeat the same thing again to them, not without wasting their time. And then if their understanding is slightly wrong or different, so that I can correct it from there. And then I start with something which gives them hope. Start saying that blood picture is not showing typical cells, and these atypical cells can be due to so many reasons, which is infection, some atypical infection, and sometimes malignancies as well. No matter whatever the situation is, we are living in the era of advanced medicine, and then these things are treatable. So as a first step, we are doing this
So giving them hope. You're
investigation,
giving hope.
giving them hope. Don't take hope away from them unless you are doing end of life care discussion. That's a very different type of communication when we do. But breaking bad news, giving them initial diagnosis, don't take the hope away from them. uh, uh, make them understand some brighter aspects, but uh, uh, don't hide the realistic diagnosis from them either, and saying that okay, then further we have done this and we have ruled out infection. This is not an infection. This is some type of blood cancer. And then uh, we can say that your child is on the right path of treatment, and we are very hopeful, and we are getting you in touch with specialist cancer care hospital, and then they will look after your child. So that yes, we are not hiding any information from them, but we are just wrapping them in nice words and making them understand what the situation is. As you evolve over the period of time in your career, you have got clarity of your thoughts, good knowledge, then eventually the clarity comes in your communication as well. And clarity, sometimes detailing is good, but brevity is even better, that you can explain the same thing in shorter sentences, in fewer words.
Excellent. And I think it goes without saying that it is good to prepare yourself as a doctor before you break bad news. Like, don't walk into breaking bad news by just reading a small note about the condition. You have to rehearse how you're going to say it, explore specific words you're going to say, and make sure that they, as you mentioned, make sure they understand what you're saying, because you may say one word, it will shut them down and they would be able to understand anything. So always good to check, and thanks for mentioning this, always good to check with the patient family and the patient, depends what age group you're treating, that they have understood what you've said. And you could ensure this happening by asking them what have they understood so far, and then they'll repeat to you what they understood, and then you keep going on. So you are an experienced consultant, and you're a mentor, you're a teacher, and you lead a team. What specific 3 top mistakes you've seen happening from some doctors when they break bad news, or when they communicate it's like a grave outcome from an investigation to the patient and patient family?
It is funny the way I'm saying it now. Um, Sometimes we have medical knowledge, we read about all the rare problems, we read about serious problems, and when we see something serious and something rare on the investigation or anything like diagnostic work you are doing, we get excited. Wow, we have found something very different, very unusual here. And then that excitement sometimes is conveyed to parents in a wrong way.
Okay.
uh, Generally speaking, if as a physician, if you get excited about a diagnosis and of a patient, generally it is not a very good news for them if you get excited.
Of course, yeah.
Uh, so keep your excitement contained. And then in NHS, when we are working, it's not a lonely word. You have got a whole team around, your own team, multidisciplinary team. And never try to approach such things single-handedly. Have your team consensus before you go, and then make sure that you are adequately prepared, what you are going to say, what you are not going to say to the parents, sometimes, and patients. Sometimes the problem comes when different professionals give slightly different information,
Of course.
and then it confuses parents. And then second thing, that documentation is inadequate after giving the news.
Okay.
Uh, uh, Many times problems they come when you claim that we have told this thing, and then patient says that I was told this thing, and that controversy comes in, and you can always lean back on your documentation. If documentation is of good standard, uh, it will defend you, it will save you in those circumstances. uh, Try not to give your own opinion, try to keep yourself very objective when you're breaking the bad news. If you don't know anything about certain situation, just be honest, just say that I don't know, just don't make things up, don't discuss your gut feeling with them.
Totally agree on this. Totally agree on this. There's no point and there's no place for gut feeling. You have to give something based on research, based on investigation, based on clinical tests. No, thank you so much for sharing this. So the three biggest mistake you mentioned here are very crucial, and I will stop more at the last one, which is communication or lack of documentation. I will stop at the last one, which is lack of documentation, which is a very important, and actually it is a recurrent theme through my interviews. Is they always mention that some doctors, and we have to say mostly overseas doctors, they are not great with communication. They are not great with documentation, which means they'll have a conversation, but they don't document it. And medical legally, if you haven't documented the conversation, it hasn't happened. So, and let's let this sit down. If you haven't documented a conversation, a consultation, an outcome, treatment plan, or discharge, it hasn't happened. So if anything goes wrong with this patient management, not related to your specific treatment with this patient, it will come back to you because you haven't documented. So make sure you document everything. And actually, I think it's a good time to drop this in. I've actually created a little small booklet on the 6 common mistakes overseas doctors make, and one of them is documentation skills. So for every one of you guys, if you want to download the book, I will attach a link and I will give it to you for free. So you could just go and download the book, read the book. You could read it in 5 minutes, but it will give you an insight about what most common mistakes overseas doctors make. But thanks for pointing out to this. I think it's a
Can I just bring one more
of
point
course.
in that? So, documentation inadequacy is the source of error as well. Uh, 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 I will put it that way. Something did happen. I will share my experience. In neonates, we do uh, head cooling and whole body cooling for hypoxic ischemic encephalopathy, and there are certain criteria. If baby meets those criteria, baby needs to be cooled. My center where I was working as a consultant, that was not a cooling center. Baby comes in, I think that baby does need cooling. I speak with cooling center. They say don't need to cool. So, because they think it's an infection rather than ischemic encephalopathy. So I did document my thing, that spoke to this consultant because I'm concerned about HIE and advised not to cool, and we didn't cool the baby, and baby started to have fit. And then baby was transferred to a different cooling center, and then they questioned our decision. Eventually, it did become a medical legal case.
Okay.
And then the center who advised us not to cool, they didn't have any mechanism of documenting these communication either. So this case, like 10 years down the line, is going on. Uh, but my advice would be, it is very important to write the whole documentation, that I gave this information. On the basis of this information, I gave this advice. So it will be like kind of close loop communication. We call it as closed loop communication rather than documenting open ended communication.
Thanks for sharing this experience. Really appreciate that. And I can, again, comes to my mind now a program which is very famous on TV called Location, Location, Location. When you buy a property in the NHS, in your profession, documentation is what will keep you safe, will keep the patient safe, and will keep your trust safe. Because we are these three components of our service is linked together: ourselves, patients, and the trust.
Yes,
If we document, we protect all three.
absolutely. And now when the electronic system has come up in most of the NHS trusts, it is not as common in overseas hospitals, and every documentation is audit trailed. So anyone accesses the documentation, if you go back and change it retrospectively, it will be audit trailed as well. So don't mess up with the records, don't change anything.
Yeah.
Sometimes because I'm in charge of one of the EPRs for neonates, and I do audit some benchmarking criteria, and I can see like some information is adequate, some information is inadequate, some information has been changed 1 week after it was entered into. So
Which yeah.
that is not appropriate. You have to document generally prospectively, and if you have to go back retrospectively, make some prospective note,
Sure.
and then go retrospectively
And
to
there's nothing wrong with this.
there's nothing.
If you miss something at the beginning,
Yes.
which could be seen as a mistake, don't do another mistake by going retrospectively editing it, because it will be audit trail, so they will find it out. So doesn't look good
Yeah.
on you as a doctor, and also it's not needed. And thirdly, it's very well safe to do something better, which is correct the mistake and say this is what we found now. Like we do this in radiology. If I was reporting a scan and then something was missed, so
As an addendum.
we add them an addendum, because this is something you can sometimes ask me, what do you mean by this? And I say, okay, maybe I wasn't clear. So I'll add an addendum
Yeah.
to document that you asked me to look at it.
Yeah.
Or if I want to give a second opinion, it doesn't make any sense for me to give a second opinion on the phone without documenting it, because
Yeah.
if anything goes wrong, which will they rely on, my opinion or the original report opinion? And then I will get you in trouble as a clinician if I don't add the addendum, because you will act on my advice, but then something goes wrong, the report will tell you, oh, you didn't act on this. Oh, Dr. So-and-so mentioned that. So the moral of the story is documentation is essential. Do it as you go. And if you find something needs rectifying or change, it's okay to add an addendum to change the information. I think this will add clarity, will show integrity. And this also will take us to another important topic, which is the duty of candor. So if our duty is to mention if anything goes wrong and patient come to harm, we have to speak to the patient honestly and transparently on what went wrong, what we're going to do about it, and how we're going to mitigate it. So we do this in radiology, but could you share how is it in your work,
Yeah.
pediatric? Because it's a bit
Yes.
sensitive as well.
Yes. So uh, in NHS, we have got a strict governance culture where if any mistake happens, near miss happens, it is reported through an incident reporting system. We call it as datix at the moment, but you may have different names, and the new name is coming up for the same system. But it is basically an incident reporting. Whenever we report an incident where a patient is involved, it is our duty of candor to be open and honest about the mistake with parents and patient, to inform them, to apologize them that it has happened, and we do it regularly. I'm not saying that we make so many mistakes, but if we make mistakes, we are not shy of admitting it, so that the whole process is improved. We learn from the mistake and it doesn't happen again. And then all the duty of candor communication we document in the notes. For example, there is a baby in neonatal unit. Parents, they want to give them a certain formula milk. You give them wrong formula milk, or nurse gives them wrong formula milk. You document it as an incident, that this incident has happened. You go apologize parents, just to say that this was done, it was an oversight or it was a mistake of the system, and then we are rectifying it. And most of the parents, they appreciate that we are open and honest, and they can trust ourselves for looking after their patient
Right.
child.
Thank you for sharing this. This also brings another emotion to me, is we as doctors, we don't like to do mistakes, of course, like everyone. I mean, we're not saying only doctors, but when we do mistakes, we feel bad about it because it involves other person, which is the patient. And in some other healthcare system, it may not be the case. So what's your advice for any doctor coming from any system in the world coming to the NHS? What's your advice to him or her on what should they do when anything goes wrong, even if it's not something they've done before?
So, first thing is prevention, that if we follow the processes and we stick to the guidelines and protocols as much as we can. But yes, mistakes do happen. And as soon as we realize that mistake has happened, uh, uh, we have to be honest about it. We should not cover it up, because in NHS we have systems where mistakes can be reported even by the individual who has done it. For example, if I have taken blood sample in the wrong bottle, I will report it that yes, this mistake has happened from me, because I took the blood sample instead of pink bottle, I took it in the yellow bottle. It means I will have to take another sample from the patient, or this sample might not be processed, or there might be delay in getting investigations. At least this thing is highlighted, rather than hiding the problem and then someone else discovers, so okay, this patient did not have blood sample and there is delay in sampling. So you yourself can report the incident by yourself, and then you can write your own reflection in your portfolio or appraisal that it has happened and I have learned from that, reflect on that, and then move on.
Thanks for sharing this. This is the technical part. I'm talking about the emotional part. How to convince me as a doctor to admit that I've done something wrong. I know you talked about the technical part. You just go and admit it and do it. For you, it is second nature now. But
Yeah.
for some people, it may be, I feel very uncomfortable about reporting I've done a mistake. I'm putting my hands up. I'm wrong. I'm bad. This is how it feels to them.
In the beginning, yes, it can be very difficult if you're coming when you think that you are being judged by everyone, you are being assessed, and you are trying to prove yourself into the system. If mistake happens, you feel bad about it, and then it can be emotionally daunting. I want to reiterate this fact, just to make you believe that there is nothing wrong, despite you feeling emotionally uh, bad that something bad has happened. It is better to discuss if something has happened with your colleague, with your seniors, and act on that.
Perfect. I also would also add to this as well is it's okay to do mistake. We all do mistakes. So you are a human. You are not a superhero. You're just a normal human doctor, and you can do mistakes. But the good thing about the system in the NHS, it allows you to report the mistake and not judge you by it, and even will give it a different positive input that it will help you to reflect and improve the whole system. So reporting incident is actually a positive thing to do. It will elevate you. It will help you understand the system better, and will protect all patients and protect yourself as well in the future from doing the same mistake.
Absolutely.
Yeah. Okay. In 60 seconds only, I want to ask you a couple of questions so we get the top of the top advice from you. How do you lead a team culture, and how do you manage your huddle with your team every day?
So when we have a team with a clear leader, in this instance, when I'm on uh, in the ward, I'm the team leader. So it is very important for me to communicate clearly with the team what is our shared goal, what we are going to achieve, and allocating role to different team members, and making sure that they understand their role, and then close loop communication, that whatever task is assigned to them, they complete it and report it back to me, so that there is no small team leader evolves within the team, which will disrupt the team dynamics.
Next.
So keep the leadership in your hands if you're leading the team. And if you're not the leader, if you are the member of the team, behave like a member and report to your team leader, not to the third person.
Perfect. Thank you so much for sharing this. What about also in 60 seconds, books or courses that you swear by and you would advise everyone to read or to go to?
Leadership and management courses, there are so many in NHS. Uh, I don't know the specific names of the courses, but every trust, they conduct those courses with their different names within the trust. One course is on influencing style. Like it is a very good idea to get uh, some understanding of influencing style, whether you lead by example, or you motivate people, or you persuade people, or you get them or you get your work done by assertion. So these are the influencing styles, and if you have got certain influencing style within your personality, it is good to switch over between those. So learning about influencing style is kind of a course people they can do.
I want to ask, this is going to be our last question, but thank you so much. Really enjoyed the discussion with you today. This is my last question to do. I have in my ultrasound session, when the patient is very tense and they're worried about the outcome of the ultrasound scan, I have a specific phrase I use to diffuse the tension. And I always tell them, there's nothing exciting about your scan. It looks very boring. So they smile, they become relaxed, and they become more conversational, and they relax throughout the scan. Do you have a specific phrase word you use to diffuse the tension with patients or patient families, or anything that you could say or you say to them to help them calm down and, start to listen and understand what you're, trying to convey to them?
So most of my patients, they are children, and they are apprehensive about like what am I going to do with the scanner. So one thing, I just use the word jelly on your belly. So they'll quite like jelly on their belly, and I then say
Makes it fun. Makes it
yeah.
fun. Yeah.
And then I say it won't hurt you. I promise it won't hurt you, and you can tell me if it hurts.
Okay.
So many of these children, they get relaxed, and then I ask, then I say, do you get it? Give me high five. And then many, even small like infant or toddlers, they give me high five, and then that diffuses the tension.
Excellent. Excellent. Thank you. I really like this. Thank you so much for sharing this. I actually will use it from now on. Thank you so much for sharing this. I really enjoyed this. What an interesting and what a useful and very entertaining discussion we had today. I personally benefit from the information you shared with our audiences, and I'm sure they all will benefit from this. And yeah, thank you so much for coming and giving us your time. And I will end the meeting with the way you end with the children. High five. Thank you.